made a couple of quick notes, and then I can also do questions. Unrelated to study session, but on your schizophrenia patient reviews, I noticed one thing, you do them and you learn. In the future, I gave everybody credit if you completed it, what your score was, but in the future, you need to have a passing score to get full credit for those patient reviews. You can take it multiple times, but I got a lot of things that were in maybe the 20s, 30s, 40s, and so, we need to probably take it until we have a pretty good understanding of it. The other thing I'll tell you real quick about diabetes lecture on Tuesday is when I was up here during lecture today, I noticed there's a crossword and some handouts at the end of those slides of the word guide. Ignore those. Don't worry about those until after class Tuesday, and I'll take a look at them and make sure they're going to agree with what's in your other slides and all those things. So I don't want you guys to spend a lot of time on them. I want you to study for the test instead. Anyway, okay. I looked at Blackboard, and there was a question that just came up that I hadn't had a chance to answer. It was on schizophrenia. The part of it was Objective 10. Objective 10 for schizophrenia is health promotion. What do you guys think might apply to health promotion for schizophrenia that we talked about?
General hygiene.
What did you say? Eric, you might.
Can you repeat that?
Well, one of the questions I just saw on Blackboard was about health promotion for schizophrenia.
Nutrition. They don't eat.
Right, medication adherence would apply, nutritional basic needs would apply. What about people who haven't been diagnosed yet? When do we want to diagnose them?
After 3 months.
But when would we want to start treating them? It's a good point. Yeah, we want to treat them early. You're right. We don't give them a diagnosis for 6 months, but we would want to start treating them early because they have a better prognosis, right? So that's one of the health promotion things. And that list of signs that we kind of looked for, that if you saw these in people that were kind of in that age group, those kind of beginning signs and symptoms, we want to go ahead and get them evaluated professionals so they can get on treatment early. Any other thoughts on that? Kind of thought I would pull that together. Okay, and then the other question I had on Blackboard related to NMS, it talked a little bit more about, I was kind of trying to sort out, I didn't go into a ton of detail on that because there's just, neuroleptic malignant syndrome. There's so much information in this lecture. I didn't go into a lot of detail on that. You will be fine as long as you know kind of the stuff we talked about in lecture. Most importantly to me, what's the timing? When are you going to be looking for it? What is it going to look like? What are you monitoring to find it early? As far as like nursing implications, that's my major. Monitor it for it, recognize it, and then basically you're going to hold those meds and notify your provider. There are, right.
For NMS?
When does it happen? What does it look like? Are you going to monitor for it? What signs are you looking for? Those kinds of things. There are some meds that a provider might put them on, and those are discussed in your book, but I'm not super worried about you knowing those things right this moment for that part. If you want more info on it, your book addresses it on page 131 in a couple of places, and page 143 if you just want to know more. Those are not, in terms of the test itself, I'm going to stick with the stuff that we presented during lecture. Does that kind of cover that question? Does anyone have further questions about that? Any other questions about schizophrenia overall? Okay, and then what else did legalities. Questions about legalities.
Just hey, if somebody has been voluntarily admitted for like EOD, can they refuse like medications and stuff like that?
Yeah, even if they're involuntarily admitted, unless they've been incapacitated by court until that court hearing has taken place and that kind of stuff, they can still refuse things because they still have that patient right. The only time they lose that patient right is when somebody's appointed to be their guardian or conservator, because that person then gets that right to consent or refuse for them.
Okay, and for HIPAA rights and stuff, on their like medical charts, if they're incapacitated, do they hold those rights or does the conservator?
The conservator does. Those rights would pass to the conservator, so they would then be the person who had those rights to review the chart and request corrections and
Okay, just
basically everything that is their right passes to the conservator or guardian only with the court order.
Thank you.
You're welcome.
We have a question in Enid.
Okay, so talking about the same thing, the involuntary, well, they're not really involuntary that long before they go to court or a hearing to make them stay there, right? So like,
Right. Was that like the EOD question, like how long, is that what you're saying?
because normally like I know they're in there for 5 days, like 120 hours or 72 hours under EOD. Under that they can refuse, but let's say they go to court and or the hearing and they say they are a danger, that's when they lose it, right?
Not technically, they would, even if, they can be short-term, like they would move into that short-term treatment phase, but unless they've technically been incapacitated and given a guardian, they still have the right to consent to refuse treatment. So basically, just because we say somebody needs to be in treatment, doesn't mean that we can do whatever we want to them
So
without their consent.
Okay, so you can keep them in there. You can have the ability to keep them in there though.
I mean, you would have the court order to keep them, but unless they have a guardian who can make those decisions for them, they still get the right to consent to refuse treatment while they're there.
Thank you.
You're welcome.
So really, they have really all the rights.
Right, and that, once again, comes from those times when they were not given those rights, and like, once someone was admitted, basically it was assumed that all their rights were gone, and so that's why the court has kind of clarified these things and made it a little part of the process to protect people.
So with that, if there's an adolescent that their parent has put them in a mental facility, can they refuse treatment or?
Technically, no, because they're not their own guardian, their guardian will still maintain those rights.
Okay.
Anything else? Yeah. Yeah. She's asking, I don't know if you guys could hear that on the definitions and legalities, that kind of just the difference between and things like that. Yeah, I mean, as long as you kind of have a grasp on what they are and how one thing different from another, kind of the things that fit under the definition of malpractice and negligence. No, there are not any questions about where a specific thing like came from. Her question was in depth on common law, and I can tell you there aren't any questions that specifically say that a certain legal case contributed to this.
You differentiate between negligence and malpractice a little bit more.
Does anybody know the answer to that? Right, malpractice is professional negligence. So as a professional, if you're guilty of negligence, that is malpractice. Whereas if you think about like a parent can be negligent in their care of a child, but that's not malpractice because they're not a professional in that job. Does that make it make sense? You have to be a professional to be able to be guilty of malpractice. You have to have a professional practice basically to do it badly. Yeah, because you have a license, so a nurse can be found guilty of malpractice. Right, it's a professional person. Yeah, basically there's similar definitions. Malpractice just adds the licensure and professional component. There are more like, I don't know the answer to that because I don't do a lot of, she was asking me if there are practice tests related to these specifically. I kind of looked at legalities because I was thinking about doing a quiz and I didn't necessarily see things specific to that. I don't know about schizophrenia, honestly. Maybe mental health stuff. Anything else? Okay, you're up, Ms. Martinez.
Questions about the defense mechanisms, violence, suicide, communication. There was so much in there.
You differentiate between facts and myths regarding suicide.
Okay. The question was, because it's on the theory of learning outcomes, facts and myths related to suicide. There's a myth that maybe that someone who comes in who has made maybe I swallowed half a bottle of Xanax and then I called my boyfriend. So the nurses in the ER go, well, she was just trying to get attention because her boyfriend broke up with her. She's not suicidal, but she's not going to commit suicide. But maybe in a couple of months, I would work up to a full bottle and I would not call my boyfriend. So a lot of people start, maybe they do call for help, and yes, maybe they are looking for a little attention, but maybe they're just working up the courage. So you cannot assume that because someone makes a not very strong gesture, that they won't get to a strong gesture. So I would say that that's a bit of a myth. Let me think of another thing that would probably fall under that. A lot of people, it's not really a myth, but a lot of people just assume that most suicides are by drug overdose. They're actually more by guns. Let me think. It seems like there was something else that would fall into that category. Can you all think of anything that would fall into that? I don't think that anything that would pop up on your test would be something that wasn't pretty obvious to you like that. We went over those suicide risk factors, and that kind of tells you what really is true as far as what you need to worry about, whether this person is at risk or not.
Mrs. Martinez?
Mm-hmm.
Another myth that's been mentioned in the past is to bring up the subject of suicide to a depressed patient will increase the risk of them committing or attempting.
That's a very good reminder, because some nurses are hesitant to ask someone if they've ever thought about suicide because they're afraid they're going to plant the idea in someone's head. But that has been shown that we really need to ask that question. In fact, we're required to in a lot of facilities to ask that as part of our mission to the facility. That, you know, some people will go ahead and talk to you about, and then of course you need to go on further and see if they have a plan and that sort of thing. But yeah, there were people who believed that it was wrong to even bring up the subject. And that, just because we're nurses doesn't mean we're not friends and neighbors and relatives too. If you think one of your friends or neighbors or relatives is struggling, it's perfectly fine to ask them too. You're not going to cause someone to commit suicide because you ask them if it's crossed their mind. You know, so that's a good point, Mr. Bear. Thank you. There was another question I don't think we really talked about. It was on the outcomes, suicidal self-injury and non-suicidal self-injury. You know, some people do the cutting because, and you'll see maybe scars all over their forearm where they have cut themselves because they hurt on the inside and they want to feel that little pain with that cut, because they'd rather feel that than feel what they're feeling on the inside. So that cutting behavior is a non-suicidal self-injury. But if someone maybe made one slash that was semi-deep on their wrist, you know, that's not an example of a cutter. That's someone who's kind of testing their boundaries on what it would be like to slash their wrist. So someone who we call, you know, a cutter usually has a lot of fairly shallow scars that, and they will tell you that they kind of like that pain because they might not be able to articulate it very well, but it actually, you know, it feels better than the pain they feel on the inside, which is really sad, isn't it? No questions?
So with the slides that we didn't cover in class, are those okay to just read over, or is there more information on those that we need to know about?
Where were we when we got cut off?
I think it was around page 11.
It's got risk factors, so that's important. Assessment, yeah, you would want that, you would want to, you know, be familiar with that sort of, that slide as well. Why did say page 11 isn't, yeah.
But is there like any additional information we need to know than what's on the slides?
No.
Okay.
Let me just make sure, yeah, the last one is some references, so that's just helpful. There's a little bit about family there. No, I think the slides were pretty in-depth on that.
Okay.
It says removing firearms. You wouldn't probably just remove firearms if they had a lot of prescription medications that were potentially fatal, like opioids. You probably try to limit the access to just, 1 in the morning, that's what they're supposed to take, and, besides firearms. It's sort of like having a toddler and you go around child-proof young child. You try to, and I think in our orientation, I've been to 2 mental health orientations this week, and they both did a good job of showing how you couldn't pick up the chairs because they were weighted, and not to use a spiral notebook, and not to leave a pen around. I mean, there's a lot of things that we would not think of as a weapon that someone else might think of as something. Yeah. But no, the slides are comprehensive enough on those last few that we ran out of time. Thank you for bringing that up.
Thank you.
I think we have a question in Tonkawa.
Okay.
This applies to the lecture you just did, but could you go over more in detail the information sequence and what happens in each stage?
Okay. Let me find that. There is actually a chart on that, and I think it's in chapter 17. That would be, if I'm correct, seems like it was very, maybe wrong. Stage 1. She wants to know about the 3 phases, the sequence of the inflammation, stage 1, stage 2, and stage 3. Okay. It starts really, doesn't look like there's I don't think there is a chart. So in stage 1, you have a vascular reaction, and your body, it constricts the veins and dilates the arteries so that more blood can arrive, and it starts releasing the histamine and the kinins and all of the leukocytes, and all of those things begin. So you get more blood flow, you get the edema. All of those, there's some overlap, a little bit of overlap between the stages. In stage 2, it talks about the exudate primarily, and the increase in the white blood cell count, which is also called neutrophilia. So those are the main things that happen at that point. And then it starts, if it lasts longer than just a few days, you may see some of those bands showing up if the bone marrow starts running behind. But it goes, I'm not gonna expect you to remember each kind of cell, like the cytokines, for example, is that do you have more cytokines in stage 1 or stage 2? No. I mean, that's not the kind of thing we really want you to think about. And stage 3 is that tissue repair and replacement. That one is pretty much, but there's not a time in the book. Like, it doesn't say, okay, it does say there's about maybe 72 hours or so within the first stage, but there's not a time associated with the second or the third. So, it's too early in the first one, probably, to see an increase in white blood cells if you did a blood test. It's probably too early for exudate because there's not, it's not gonna start draining if there's some damaged cells that early. But, so, and also that even at stage 1, it says it can be up to 72 hours, but it can also be as little as 24. So we're not gonna put a time frame on them, if that helps you any.
I have a question. Okay, so on the lupus versus allergy, I was trying to come across that during the lecture today, but I didn't see that.
Let me take a glance at the blueprint. Oh, I did see the blueprint. Let me see under my, let's see.
It's like a side effect of medication.
It probably refers somewhere, obviously, it must say something about allergy on the class, but we, let's see. An allergic reaction is kind of a hypersensitive reaction or an overactive immune response to something that's pretty benign. Like, let me think
So
of
like
something.
would it be like the butterfly effect rash?
Not really the butterfly effect. It's more like, it's just like allergy in general. Like, I don't know, peanuts. If you're allergic to peanuts, some people can be accidentally exposed to peanuts in a salad that they order in a restaurant and they don't know there's peanuts or peanut oil in it and have peanuts are benign to most of us. They are absolutely harmless, but someone can have a hypersensitive reaction and a huge allergic reaction and die from peanuts. So it's just kind of built into the context of immunity and your whole immune system and how it can be overly aggressive.
So like inflammation response?
That's
Yeah.
how I am with the tree nuts. I can have peanuts or I can have tree nuts.
Yeah.
To like shut my throat.
Let's see, I did tell you that, there would be quite a bit about medications on this test. I'm looking at my notes on the defense mechanism. Do be familiar with that assault cycle, is that what we call it, assault cycle? That has to do with the person, something triggers that person and then they escalate and, there was things nurses would want to do to try to intervene at certain points. Might be appropriate in the escalation phase, may not be appropriate in the trigger phase versus someone. You might act differently, you might have a show of force in the crisis, obviously, or maybe in the escalation, but probably not in the triggering, because you may just make someone worse. So I'm just using that as an example, but do go over that.
So you said like know your medications. So like the only ones we talked about, I'd say like outside of just like the normal acetaminophen and NSAID, it was methotrexate and prednisone.
Is that B1?
We talked about several medications. We
The
talked about
Celebrex.
the Celebrex, which I could not pronounce.
I had that noted. Yeah.
We talked about the new drug for lupus. So
Yeah, okay.
it starts with the B.
We got that.
Yeah, we talked about,
I only had 4.
Talking about tramadol.
Yeah.
There was like a last slide.
in the-
and it just says other diseases.
I'll go back.
Do we need to know those?
there was a last slide today that we didn't cover, and it's not something, it's just information for you. It's not test information to know about some other diseases that are similar and have some of the same challenges as what we talked about today.
So since you have the white blood cells on there, for anemia and infection, are you gonna wanna submit like what the normal amount is compared to abnormal? Cause it's under the lab and diagnostic test that we need to know.
The question was about the white blood count is on your blueprint. I don't know if it just says white blood count. Is that all it says? On your theory learning outcomes page, it said read material over the white blood count and differential count. And then it also talks about urine, which we did not talk about, so I would not worry about that one. Wound culture and sensitivity, we really didn't get to. We did talk about the ESR, we didn't do blood cultures. We talked about antibiotics just kind of on your assignment. So if I would expect you, she's asking me to give her a little more specific information about what we might want to know about a white blood count. I don't remember, and I couldn't tell you if I did, exactly what you need to know about it. I think I guess if I was studying for it, I'd probably read my lab book on that and just look at what it consists of, maybe. How I would look at it in the context of, if my patient's getting sicker, if my patient's getting better, what I expect to happen with the white blood count, that sort of thing. I don't think I told you guys when we went down through that differential, but I wasn't gonna expect you to know what basophils did versus eosinophils and that sort of thing, so, I wouldn't worry about that level of detail. Cause I know you really study details in it. So you don't have to on that part.
Ms. Martinez, on those medications, do you just want us to know, like, what they treat?
Last semester I asked really general questions on the medications, but we're one semester closer to graduation, so yes, I do want you to know what they treat, but you need to know because a lot of these medications have some pretty serious side effects, so you kind of need to know side effects and, what, not even so much side effects, let me think about adverse, things that happen to your body as a result, like prednisone. Over a period of time, prednisone can do quite a bit of damage to your body. I know I have an uncle with a lot of allergies, a lot of breathing problems, and prednisone was just killing him, basically. But he said that, his pulmonologist said, you can't be a farmer. And he said, but that's my life, he was allergic to wheat dust and all of these things. And the prednisone basically probably ended up killing him, but if he hadn't used it, he would have died a lot sooner. So, know some things about the bad side of methotrexate and all of those medications too. And, you're gonna have to know them fairly well. Better than last semester for me. I think Mr. Baird asked you in depth last semester, but I waited till this.